Today, I'm excited to be joined by a longtime friend of mine, Russ Bodner. Russ and I have known each other, I don't know exactly, roughly 20 years, though, I think it's close to. Um, and I was Russ's rep before I decided to leave Depew 8 years ago. And anyone who is on LinkedIn and in the field of orthopedics will recognize Russ and his spinal pelvic dynamic work that he has done with Dr. Dorr. So, welcome, Russ.
Thanks, Stu. Pleasure.
Yeah. So, how did you first get interested in the the spinal pelvic dynamic of the hip?
It all started in 2015 in Las Vegas at the AOS when I was wandering around and I ran into an engineer at the Corin booth, a small company who was showing pictures, x-rays of the pelvis from the side, and explained basically what the OPS, which is their planning platform, required, which was taking functional x-rays and matching their components to the way a person's pelvis actually moved. And that just blew me away. The whole fact that the pelvis moves, because I was never taught the pelvis moves. All we did was take an AP pelvis lying down and then plan your arthroplasty from that. So I thought that was absolutely incredible. And the very next day in the spine poster session, I saw a poster with pictures of the pelvis from the side with spinal fusions and saying you have to move the position of the cup because this dynamics are off when people have neurologic disease or spinal fusions. And it was confirming what Brad Miles, the engineer, had told me. And so I knew that this was something that I need to know more about. So I came home and I started researching and reading this. And it led me to a series of papers from Jean-Yves Lazenek in Paris, who had the EOS machine very early. Took a bunch of patients and put them in the EOS, which would give him simultaneously full body standing and sitting AP and lateral views. So you were actually seeing biomechanics live in front of you. And he wrote how the pelvis works, how the cup moves, different biomechanics. And it was the most fascinating thing I had ever read. It led me to read in the spinal deformity literature what these angles meant up and down the body, what was posture, how the body worked. And after all this reading, which took a couple of months, I came to the point where I said, okay, now where's the paper on how to use this stuff to help my patients? And there was none, zero. There's no way to use this stuff. So I said, oh, I got to figure this out. The only lead I had was a paper I found in 2014 in JBJS that was written by Larry Dorr. And it was clear to me that he had the same thoughts. We have to figure this out because the pelvic dynamics are real and affect our cup position over time. And so I contacted Larry Dorr cold. I called his office, talked to his secretary, left some information, and Larry Dorr contacted me back. Yeah. And so we had a discussion, and almost immediately I brought something up, and as was his style, he wanted to tell me I was full of it and didn't know anything and had no research background. And before long, it was back and forth. It was game on. And I think he really liked that. And when he talked with me, and it was all on email, I have thousands of email discussions with Larry Dorr, it became clear that I thought in a global way because I had read the spine literature and I knew the orthopedic literature, his literature, and I could put things together to say how the body actually worked like a machine. So if you want to look at these data, it should reflect how the body works. And we were a perfect collaboration. He had unbelievable data. He had lots of ideas. And then he would just bounce them off me, and we would just write back and forth by email all the time. And then he would write things up and send me copies. And Next thing you know, I'm publishing with Larry Dorr.
That that is truly an amazing story if you think about it. You know,
Remarkable. I mean, there's no way on earth the guy should even have
right?
contacted me. I mean, I'm nobody, and it was, and I knew it the whole time, Stu.
Yeah,
I knew that I was living a dream that
right,
anybody would give their right hand to be collaborating on state of the art research
right.
with Larry Dorr.
Right. Well, what's interesting to me is that it's obvious through this, even though you said he liked to be, combative with you and kind of push you on what you were saying, it's clear that on some point he was just in the search for the truth. And so
Both are.
there's a humility with that, even if he's, arguing his point, you're going back and forth. Ultimately, he wanted the truth.
We both did, and
Yeah.
I said those exact words. What only matters is the truth. We just have to figure this out, and we need to push the envelope out there
Right.
and let people catch up to us.
Yeah. Well, another thing that just is kind of crazy to me is the thought that total hip replacement, I believe it was voted somehow the operation of the 1900s
Of the century,
of
the
the century,
20th
yes.
century. Yes.
And it's amazing that something that was viewed as so successful now, with all the spinal pelvic dynamic stuff going in. I mean, even for years, people were the Lewinick safe zone, and really that doesn't mean much unless that's your safe zone, right? Uh,
Yeah.
but my question is a big part of it the fact that the patients just keep getting younger and younger, and they are probably moving more than other people, and the indications function over just pain relief?
Well, the issue with young people is that for the most part, their spines and pelvis still work well. They don't have the age-related degeneration of their spine. So it's primary hip disease in those folks. And the issue with them is self-correcting. Their dynamics are way off, and that typically they can't flex their hips and their spine and pelvis move a lot. And then when you fix the hip, a year later, they're functioning normally again. Their dynamics change completely. And in the elderly, you have the opposite situation. People in the 80s, their spines and pelvis are almost always stiff, and they won't change after the operation quite so much. The problem is because they don't move, you have to adjust your cup to their limited excursion. And typically they can't open up when they sit down. So most of these cups for spinal pelvic derangements have higher inclination and anteversions associated with them.
Mm-hmm. And we've talked in the past and even a little bit before we hit record here about, it's getting better, but there's still a confusion around this subject. I mean, in basic terms, how would you best describe to people watching this what is happening and what you are really paying attention to when you are figuring out where to put your cup?
So the whole paradigm was based on a supine AP pelvic X-ray, and it's static, so it doesn't reflect what the person is doing in life when they get up off the table and move around. So a very functional position is the standing position, and the pelvis will move typically roll back when people stand up, and then when they sit down, the pelvis will roll back even more. The total hips that we did were close to the standing position. So there's not much difference if we just stood between the paradigm we've used and a standing. But when you throw in a sitting or a flex sitting where you bend forward to tie your shoes, get up out of a chair, the components are moving in different ways. And that's the part that you have to figure out. Particularly the sitting position isn't addressed at all in our planning. And so now we have ways to do that. And you
Yeah.
have to measure the people in different positions, which not many people want to take lateral x-rays and want to measure angles because it's time consuming. And
Right.
then even if you do that, how are you going to adjust it? That's a big problem because this is data in the sagittal plane, the lateral view, and all surgeons really want to do is say, okay, what's the position of the cup that I need to hit in the coronal plane? And most of this is going to be done through planning platforms, through products.
Yeah.
That's what I've been trying to entice people and jump up and down and say, come on, let's help these docs.
Yeah.
But it comes very, very slowly because not many people are doing it or
Correct.
clamoring for it.
And the ortho industry is very slow to change overall.
I mean, they have product cycles, they have agendas,
Correct.
they have projects that they're doing, and not a whole lot maybe of excess capacity and funds to develop new products at this time.
Right. Well, to go along with that, what does the future hold in your mind around this topic, and what are you specifically working on?
What became very clear fairly early with Dr. Dorr is that we were doing all this research to measure preoperative dynamics and then plan a cup or a construct, including the femur and the cup, based on preoperative data. When it became very clear that after the surgery, people's dynamics changed, and they changed because their hip worked. It didn't work before, so you had these goofy measurements. And then if you waited a year later, their measurements would change. But they changed in different patterns. There were some patterns that were predictable, but it wasn't everybody. We need more data. We need to figure out some of the less common patterns to help people. And in the past few years, it's become clear other people have now published their 1-year follow-ups. And so what we're going to be doing is not putting in your cups based just on pre-op. It's going to be based on predictive where you're going to be in the future.
That,
And
that's pretty amazing.
yes, so you have to have data at different time points. So we have really pretty reasonable data at 1 year now, but it can go 5 years. As I'll say, Stu, in 10 years, you're going to look like this.
Right.
So I'm going to put your cup in here because it still will be safe now, but it'll get even safer in a few years from now because this is how you're going to get old.
That's amazing, Russ. So I appreciate you taking a few minutes here to talk with me. And if someone is interested in reaching out to you, I know a lot of people have in the past, and you like talking about this, what is the best way to contact you?
Well, if you're on LinkedIn, you could message me. That's a good place to start, and then I'll give you my email, and just contact me.
Again, I appreciate you spending the time with me going over this, and I hope you have a great rest of your night and a great weekend.
Thanks, Stu. Thanks so much for having me. My pleasure.
Absolutely.
Take care.